And we're recording this session. So just in case before the recording, just to let you know, this is a program of HRSA, and here is our disclosure and stuff. I'm going to stop my screen sharing right now so that I can have all of our presenters on. I want to extend such a great welcome to everybody from that's joined us. And so what we're going to do is we're going to have it sort of be this casual conversation. We're going to have the presenters, everybody share a little bit about themselves, and then we'll kind of go through some questions, and we'll have a conversation around all of this. So I was hoping maybe Marisol, if you could just tell everybody a little bit about yourself, about your family, how you kind of come to this work.
Okay.
Appreciate it.
Thank you, Molly. Thank you for inviting me to this. And it's such an important topic. My name is Marisol Rose. I am the State Parent Consultant for the Early Steps Office at the Department of Health in Florida. So that's the Early Intervention Program in Florida. And my role is to really represent the parent perspective and to also assist with technical assistance for our family resource specialists across the state. And they serve families in the same sort of capacity. They're parents as well. And sort of like a family liaison position. They assist families in accessing resources and education and just emotional support, anything like that. So before this role at the state as a state parent consultant, I was a family resource specialist myself in one of the local offices for 6 years. And what got me into that role actually were my kids. My son, to be honest with you, he was the first one. He's my oldest. And he started me in early intervention. He started at about 16 months with the early intervention program. He was born premature and had a lot of complications. And then about a year after he graduated from early steps, and then I got this position as family resource specialist. And about a year after, I found out I was pregnant again. And my daughter was diagnosed with Down syndrome prenatally. So I've always said, this is just where I'm meant to be. I'm meant to be an advocate for my kids and for other kids throughout the state. So that's kind of where I'm at now. And I love my job. I love what I did as a family resource specialist. And now at the state level, I feel like I have more of an opportunity to really educate families and to empower them and educate providers, educate professionals who work with families. So that's my story in a nutshell.
Yeah, thanks, Marisol. Try to wrap it up in like 2 minutes, right? Like I say, 3 minutes to tell me all about yourself. But we know that there's a lot more that'll come out as we have this conversation and stuff like that. Sarita, I was wondering if you could go next.
Sure, I will. Hey to everybody. I am Sarita Edwards. I am the CEO and president at the EWE Foundation. That's the Elijah Wayne Edwards Foundation. We are a 501c3 healthcare advocacy organization. We facilitate resources for families living with Edwards syndrome, which is commonly known as trisomy 18. We also offer economic assistance to those families facing economic hardship. And we do legislative advocacy, just pushing legislation to empower the rare disease community. In addition to that, I am a parent advocate. My husband and I have 5 children. The youngest, Elijah, was diagnosed in utero with full trisomy 18, and that started my efforts of advocacy and public policy. I do love sharing that he celebrated his 4th birthday this year, so we are excited to reach those milestones. And that's pretty much me in, I hope, 90 seconds or less.
Thanks, Sarita. And Linda, how about yourself?
Hey, everybody. I'm Linda Starnes. I'm sitting in the suburbs of Orlando, Florida at the moment. And it just so happens that Marisol and I work for the same entity, the Florida Department of Health. I work for our Title V Children and Youth with Special Health Needs program. And I'm the statewide family leader for that program, which means that I try to bring in family perspective and lived experience at the state programmatic development level. and just trying to be ever present in touting the importance of including lived experience voices within systems planning. What brought me here is my two children. I have two children with genetic conditions. My oldest is 28. Yeah, 28. And my youngest just turned 26. So I'm a little further along than Marisol and Sarita in the whole family experience. But they were both born with very different and very rare conditions with a lot of medical complexity. And our son is a ventilator graduate and has lived life with a trach and a feeding tube and uses assistive technology for communication. And our daughter, and they've allowed for disclosure, our daughter is a person on the spectrum, as well as has a genetic condition too. And I sit on a variety of boards and organizations related to health and disability, and I'm seeing some of my friends from those activities here with us. So I'm so glad everyone is joining us. Welcome.
Thank you. And thank you so much for sharing that little bit about yourself. And I know we want to get right into the topic and the questions and stuff like that, but I just wanted to frame this all for everyone that's able to join us today. And so this started as a conversation actually between the four of us. And we really started to talk about this idea of language and the words people use and how it really can be like a minefield, or sometimes some words you used when you were first on the journey as a parent, and then the words you use now have changed over that time and stuff like that. Or even how within different communities, we've talked about the idea of certain words are used in certain communities and others they're not. So we know that it is this kind of this place that it's ever evolving, we're ever learning and stuff like that. And so we just wanted to share our experiences around this, what our learning has been, what our journeys have looked like, just to lend a little bit of clarity, at least as far as we see it. So yeah, I'm gonna just start some questions and we'll start answering. You guys can start answering. And like I said, if anybody has anything in the chat, we'll continue to monitor that. We'll share some resources. There's lots of good stuff out there already, but yeah, let's get started. So this really isn't an easy question as I look at it. And but I just want to talk about that delivery of diagnosis, sort of that new base, or when you get to those new baselines, like something changes in your child's life or whatever. So you find out something new. And sometimes those can be really hard to hear, right? And someone said one time when we were talking about this idea of getting diagnosis and some of those words that were said to you, someone mentioned it, I'm not even sure. They talked about how there's this idea of sometimes we feel that people choose words because they're trying not to give false hope. And so this idea of not giving false hope, but sometimes what happens is they tend to strip all hope away, right? So I just wanted to talk a little bit. I know each of you guys have something to share on that, but really talk us through some of those, that idea of diagnosis, that idea of not giving false hope, but then stripping all hope away from families, and maybe what can be done about that, or what's word choices, or what maybe you wish you would have had during that time. So I'm not sure who wants to pick it up first, who wants to wade in first, but happy to hear. Oh, Linda, I think you're on mute.
I'm gonna go ahead and go first, because when I had my two children, we were back in the 90s. So the language was different then. And the perspectives that I think are the most current now were around, but not really in use. And so with both of my children, they were both NICU kids. And there was a lot of grim prognostication about my newborns, and the won'ts and the can'ts and the never wills that we were being told while they were newborns. And so that was the stripping away of hope that we were talking about. And what I needed to hear was, regardless of the fact that it was very clear they were struggling, we needed to be given some positives to hang on to, some hopefulness, even if it was just the hopefulness of, you've got the cutest little one here, love them today, enjoy today. Even that is a hope and a promise for that day. And then also, it is really hard, I think, especially with all the science and the medical acumen that we have in this world of ours, to make those grim prognostications about such little ones who we need to give as much chance as we can. And so I would say, presume about the possibilities, and presume about the possibilities that they can gain, they can learn, they can grow in their health, and then couch that with some realistic information and evidence-based information. We were just told such sad things, and words that were so hurtful, the abnormalities that they were seeing, the dysmorphic features that they were finding, the oh gosh, what were some of the other words? It's even hard to talk. The defects and the impairments. Those are hurtful words when you have just entered this world. And we're gonna move to better things, but that's the sad start.
So I'll go. For me, we got our diagnosis while we were pregnant. So we were about 22 weeks pregnant, but it was that same narrative. It was the same conversation of, this is what you're going to be dealing with. But a little differently for us, we were told our little guy would pass away. We were told to never expect him to be born. We were told that if he did survive the estimated 40 weeks gestation, that he would pass away being birthed or shortly after. And even after delivery, we were told, enjoy your time because he's going to die soon. We were refused newborn screenings. We were refused treatment for jaundice, all because a genetic disorder that he was born with was present. Because of the high mortality rate of his illness, we were denied services that our 4 other typical kids received. And so I think, when we think about what doctors can do different, I agree with Linda. I think it starts with giving you the truth of what you're dealing with, but also changing the delivery of that information. You could very easily say to a family, this is what we're seeing. There are going to be challenges, and you're in charge of what comes behind that but. You know what I mean? And I think that's what we've kind of lost. It's more doom and gloom. This is what it is, and that's it. Like what's coming to my mind right now, give me a couple of commas and some semicolons and remove the period, right? When it comes to providing information to families.
And so with my situation, my 2 little ones had very different delivery of information, of diagnoses, right? With my son, I had preeclampsia. I had placenta abruption, and I had preeclampsia afterwards, but I had placenta abruption. So he was born at 30.5 weeks through emergency C-section. And I was told that it was going to be touch and go. Touch and go, we'll see how it is. We'll see if we can have him in there a little longer, but he wasn't able to stay in more than 24 hours. So I delivered the very next day. And then he had brain bleeds, he had blood transfusions, he had a number of different things going on. And I felt like a deer in headlights. I didn't know what was going on. I was confused. It was something that completely caught me off guard. And I kept being told that, he was likely going to have delays. I didn't know what that meant. I wasn't prepared for any of that information. So when I went home, and settled down, I started to realize that he did have delays, and I started to question my ability to parent him. And because of the way that the information was delivered, because it was made me feel like there was just little hope, there was hope, but little hope. And then he was later diagnosed with craniosynostosis, which is when the plates in the skull fuse prematurely. So I understand what Linda was saying, because they kept telling me that's a deformity and it could cause a lot of other complications later in life. So he went through all of that. I call him my alphabet soup because he has had so many different diagnoses over the years that with every time he was diagnosed, it kind of made it a little easier for me to accept, because I understood my coping skills and I understood what Gordon, my son, who's now 9 years old, I understood that those are just a part of who he is. And there's so much more to him. But initially, it was very difficult to accept those diagnoses. With my daughter, my son was 4 years old at that time, and I was diagnosed prenatally that she had Down syndrome. And again, I got the doom and gloom, like you said, Sarita. I was told at about 23 weeks, it was confirmed that she had Down syndrome. And I had to make a decision quickly because my window of opportunity to terminate was coming. And because I had elected to have testing done, I didn't want surprises. I wanted to know everything that was going on with my child. So I asked for the amniocentesis. But because I did that, my doctor had assumed that I was going to terminate the pregnancy. And he was surprised when I said, no, I want this baby. I committed to her already. So that was really difficult. That just the way that was delivered, the way that it was presumed that I had already made a choice when it wasn't even really asked. It was just kind of an assumption. And there are statistics on babies with Down syndrome. A lot of them are terminated prenatally, and I understand that, but I decided not to. And what I decided to do at that point was to seek out information from other parents, parents who have children with Down syndrome. So I got really involved with our local Down syndrome organization and started meeting families and meeting other people and children with Down syndrome. And I realized that there is hope. It's not doom and gloom. And, when it was delivered to me, they said, we just don't know how severe it's going to be, where on the spectrum she was going to be. And, all of this information, I kind of felt prenatally that there was little hope that she would be able to do anything, that I would be able to be a good parent for her.
Wow, you guys, there's lots of comments and questions that are popping up in the chat. It's great to see. I should have prefaced this with this webinar. We had people register whether they were parents of children or people living with lived experiences and conditions and stuff like that, as well as providers. And so I think it's a great place to have a conversation when we can have all of those different stakeholders together. And so again, I appreciate all three of you and your vulnerability as you share these very super personal stories that oftentimes trigger us as we remember when we heard those words and how much they hurt. So let me just ask you this. I think this is an important one because I think this might be on a lot of minds of some of the providers that are with us. And so this one's from someone who's aspiring to be a genetic counselor, right? And so they asked, is it better to give as much information as possible to parents up front, or provide information as parents request it, so not to cause that information overload? So again, it's sort of, to me, that chicken or the egg sort of question where there's maybe not a right answer, but I don't know. How you feel about that. And I get, so this, I think is sort of like where we started, right? It's all very personal, and it's very independent of each family. And so it's hard to give that definitive answer, but I think we're hoping to try to give some sort of guidance or resources on how to pick up some of those clues.
Mhm.
So
So I think,
Go ahead, Sarita.
Sorry, Linda.
No, no, no.
I was just going to say really quickly, I think it's important to read your patient. You know, I think it's really important to feel the vibes of what you're saying and how it's being received. And I say that because, you know, during our experience of getting that information, the doctor was giving me the information and I was just getting more and more, just not okay, right? Like I'm laying on the table in the middle of an exam, still partially unclothed, and he's delivering the information and I'm just bawling. And he just kept giving it, just one statistic after another, this is what you can expect after another, one diagnosis after another, all the things that we would deal with. And my husband had to say, okay, can you stop for just a second and give her a second? Like he never caught on, not sure why, but he never caught on that I might need a minute. My husband had to stop him and say, she clearly needs a second. Can you give her a second? And that's when he stopped. I think we have to get to a place to where even as practitioners, we read that energy. It was clear that a pause was needed because of how upset I had gotten. So do I think giving the information is important? Yes. I don't think you should withhold information, but I think you should be very delicate with the information because of what you're giving to the patient.
So, wow. And that was a new part of the story, Sarita, that I hadn't heard. And we've got to compare notes because I was on a table too in a perinatal event as very similar. But I will also say in answer to the aspiring genetic counselor, yay, first of all, I'm so glad you're pursuing that as a vocation. It's wonderful. But Sarita is exactly correct. You need to get a feel for who that person is, who the family is that you're delivering that information to, enter into that conversation carefully, but to give the spectrum of information too many times, and it's still happening today. And Marisol, I'm going to use you as an example with Down syndrome, that the most dire of the information about those with Down syndrome are given many times without giving the whole spectrum of information and the very positive sides to all of this. And this is your child they're talking about. And so it's okay to give information, chunk it out, and stop and ask where they are in the process of taking it in. Give them that time, that think time, that catch their breath time. Ask them if they're ready for more information or what their questions are, and take it step by step as you chunk. And when you realize there's been enough information put forward, leave the door open for them. They're going to go home. They're going to be talking in the car. They're going to stay up all night. They're going to be ready with maybe another question or two in the next day. Leave that door open for them and respond, especially with these new and very challenging diagnoses. And then I'm going to also say, somebody else asked, who gave the diagnosis? Well, we had multiple doctors with both of our children. And so the information was coming fast and furious from different practitioners and coming from their lens of specialty. And so it's sometimes conflicting information as well. So that would be the other thing that I would say is, you providers need to realize we're hearing myriad of messages, and there needs to be a concerted effort, especially with the most serious of conditions, that parents aren't made even more confused and scared by the fact that they're hearing different messages.
That's a really great point, Linda. That's a really, really great point. We got our diagnosis from our maternal fetal medicine physician. We were never referred to genetics or a genetic counselor. So like Linda, I applaud you for choosing that path for yourself. It is so needed. And I wish someone had connected us to someone sooner than we actually found one ourselves. And so I just wanted to say that was just a really, really great point, that the information needs to be consistently given across the board, and not have the continuous pull the scab off the wound experience, as you go to every other doctor's appointment. So
I agree 100%. I had information coming to me in all different angles from all different people, from my OBGYN, from my maternal infant health specialist. And you're right, some of the information did not mesh. It was not the same. It was not delivered necessarily accurately. It was a lot of the extreme possibilities of what Down syndrome meant. And none of them offered resources where I can actually speak to other families and really understand what the lived experience is. None of them offered that as resources. It often felt like I was being interviewed, the questions and the way that the questions were asked. And I'll be honest with you, I felt like I was being interviewed to be a parent, and they questioned whether or not I would be a good parent for my daughter. They asked about my income. They asked about my education. They asked about how emotionally fit I would be to handle this person until adulthood. I mean, the way that things were put, and it's not what I say to my husband, I say to my kids, I say to everybody, it's not what you say, it's how you say it. It's the emotion and the implication behind the words that you're using and the way that that information is delivered. And also making sure that you are delivering accurate information, not just like Linda said, the extreme circumstances, what's the worst possible thing that can happen, because that's not necessarily always what's going to happen. And in doing so, you're already automatically assuming that you know what that child's future will be like. And the truth is, nobody does. No parent does. No doctor knows. And no doctor can predict the love and connection that a family will have for that child.
I'm just pausing for a second. That was beautiful, Marisol. Like that, seriously, that those were beautiful words. So thank you for sharing that. I want to just move us on just a teeny bit. So I want to talk about the evolution of language. So I know Linda and I have been around a little bit longer in this parenting world, and but how words change. And so even the idea of how words change, I like to think it's interesting how words change within your own family and how words change within society, right? So maybe if you guys could talk about that a little bit. Maybe were there words that were first thrown out at diagnosis that you were like, oh, this is the words we used when we first found out, but you know what, this is how things have evolved in our family. Or if you want to talk even on a society, we can talk more on that type of change as well. So
OMG, Molly.
right.
What do you mean words change? Yes, of course they change. They change based on society, right? Did you ever say OMG
Yeah.
before? I mean, of course words change, and they change oftentimes because sometimes words will start to mean something different than what they were intended, right? And specifically, I'm thinking of the R word, right? Retarded, that word, which is often used as an insult and the butt of jokes. And, you know, what that implies is that that person who in the past would have been diagnosed as mentally retarded is worth being used as a joke. It's not appropriate. It's not right. And it belittles people. It disempowers them. And I've heard that. And I got to say, I used to use that word too, right? I mean, I think a lot of us did. I didn't understand the implications behind it. So that word I've had to correct many families, many people, my own family, and encourage them not to use it because of what it means and what it means to my daughter's future and other people's future who have intellectual disabilities. Um, it is not okay to use them as a joke. It is not okay to use them as an insult. They are human beings and they are worthy. They are worthy of dignity, of respect. So that word really gets to me.
Mhm. You know, I think, sorry,
Yes.
Marisol. I'm sorry. You know, that was the same word that I thought about as well. I think one of the one of the challenges when it comes to language, especially in genetics and how we look at diagnoses and just the medical model of language. A lot of it comes from healthcare providers and practitioners, right? Like it comes from the healthcare space. And once the healthcare space evolves and learns something different, the challenge is society they don't know that evolution has happened a lot of times, and they've already adopted that word as the right word for the child or the family, the diagnosis or whatever the case is. And so I think the biggest challenge is getting our healthcare system to embrace words and use words at the forefront. So once they reach society, they're already appropriate. Now we know that times are going to change and words are going to change. Like we know that that's just evolution. That's what happens. But I mean, when you think about years ago, nobody thought retarded. Nobody thought that word was inappropriate because it was the word being used, right? Like that's the word that was there. Um, and again, I think that's the challenge in society. We're behind what healthcare systems use as far as language. And I don't it's like Marisol just said, you have to create the conversation. That's why conversations like this are so important. So folks can know, yeah, that's not the best word right now, and use something different. I think until they're exposed to that, they don't know. Sometimes it's intentional, sometimes it's completely innocent, because they don't know that those words are now offensive to the disability community.
And so, I come at this from a lot of angles too, from that individual and family level of language versus as well as at societal level. And, the mention of the medical model that drives so much language around genetics and healthcare in general. And it bleeds over into our societal norms of how we take in that language. And so there's the whole, so some people may be not even realizing, well, what do you mean when you talk about medical model versus a social construct or a social model about disability and about those who have complex health care needs, et cetera. And it's coming from that construct of looking at strengths, and that also seeing that it's the person with the disability. Yes, they have a disability, but it's what's around them. It's all of what's around them in society that exacerbates the situation. Are we providing full access across all platforms, from education to recreational and to healthcare? And are we doing it with the looking at the whole person, and just all the appreciation that it's a societal construct that is much more important to come from for that whole person. The other is this idea, and it's another word that a lot of people haven't heard before, but just like we talk about racism, there is a term called ableism. And if you're not familiar with that term, that would be one I would highly suggest looking up and reading more about it. And there'll be some resources that will be shared either in chat or when this is sent forward later to everyone. But that's a very important term to be aware of, because it's a form of it's a form of bias and it's an ism. And there are microaggressions that are utilized. And when people are around the world of disability. And there's also a new term that's being used more and more, and that of health privilege. My son has never known true health privilege. And that is because he has lived a life that he's categorized as being medically fragile. And his medical condition informs his daily life in some ways. So there are all those kinds of perspectives to be aware of, and your own internal biases when it comes to language and the understanding of seeing people as people first. And I'm not talking the language for just seeing them and acknowledging them as people first. And the other thing that I'm going to suggest is, if you've never gone to the World Health Organization and read their statement about disability, the very first line is, disability is a part of being human. And that's where we all start, is it that these are humans that we are dealing with, whether they are in utero all the way to 99. So
I noticed a comment in the chat that mentioned the concept of fixing. And I think that's the medical model, right? That's your child, they have this disability, they have all these problems, they have all these things that need to be repaired. And that's how the medical community views it, which strips away that identity, right? It strips away their own individuality. And that's the social model, is understanding the individual and how systems impact and how society views that individual. That's the social model versus the medical model.
And sorry, go ahead. Well, I was just going to say, so there's the idea of fixing. Not everything has to be fixed. The personality of a person who's on the autism spectrum, you don't have to fix all of that. But there are some things that are medically necessary for them to sustain life. So we had to always tease out that difference for our son. Is this surgery fixing something and we put him through all that again? Or is this going to be something that is very much life-sustaining and important? And because our family dealt with 40 surgeries. And so you really, by the end of it all, you were weighing out how much of this is, let's just not fix one more thing just for the sake of fixing. And now that he's of age, and when he was of age, he started very much saying, I don't want to do that surgery. Is it necessary?
That's a really great point, Linda. We experienced that as well. Statistically, infants, babies with trisomy 18, they have G-tubes. And we were offered a G-tube when our little guy was probably maybe 6 or 7 months old. I can't even remember. And they set us up an appointment with the surgeon and everything. And we went in asking those same questions, like, so why are we considering G-tube? He had bilateral cleft lip and palate. We spent the first 6.5 months of his life on hospice. And so we were at this critical point now, hospice we've aged out of, but now they're offering us a G-tube. And so he had been bottle oral fed the entire time up until then. And we were told that it would make life more convenient for us. It wasn't a need per se. They felt like it would make life easier for us. And I remember my husband telling the surgeon, we're parents. Life isn't easy when you're a parent. Like this is a part of it. And we ask for those nutritional goals, just give me what those goals are and let us see if we can meet them orally before we just put a G-tube in, because it's more convenient. And we reached and exceeded those goals, and he's never had to get the G-tube. And so, I think that's just even understanding the importance of speaking up and advocating for yourself and for your children. How many families would have just accepted the G-tube because it was offered, because they didn't know to question again, why conversations like this are so important, so we can empower patients and help them know that it's okay to ask for another solution and question and what you're being told is the only solution, because most of the time there are alternatives to what you're being offered.
Yep. And with my son, when he had craniosynostosis, it was explained to me why they needed to do a cranial vault reconstructive surgery on him, because like as Linda mentioned, there are times when there's something that needs to be fixed for their survival, for their future, for their benefit. But my son has autism, and I don't want to fix his autism. If anything, I need to learn his way of viewing the world. I need to better understand it so he can be successful. And those around him need to understand his viewpoints and the way he feels and sees, interprets what he's seeing. He's very unique. He's extremely intelligent. He's an amazing child. But if you don't get to know him and you only see the behavior issues as a problem, instead of trying to understand where those behaviors are coming from and why, then you're failing to really give him his full potential. You're stripping away that individuality.
All right, so we have about 15 minutes left. There's lots of stuff going on in the chat, which I really appreciate all of that engagement and stuff like that. So I hope people can read along on some of those comments, but I would be remiss if I did not mention, and a couple of people have pointed out, about as families get diagnosis and they get information and stuff like that, the importance that connecting to other families has in that journey, and that there's lots of opportunities for that. And again, if you're on that professional side of building these systems of care, and it's just one piece of where families get that information, right? So when we talked about you're getting that from all different providers and a multitude of those and your family, but yes, how other parents and how other families navigate these waters is so important as part of that journey. But I just want to add, so we have like 15 minutes left. So I am just going to ask you guys one more question. And if anybody has any questions that they want us to address in the last 5 minutes before we wrap up, to please put it in the chat. But we have had some discussion about this, about the idea of individual or identity first language. And do you have a preference? And maybe I should preface that about when we talk about individual or identity first, what we mean. So I have 2 children who are deaf, and in the community that they operate in, it's either you can say that, it's a deaf child, or you can say it's a child with deafness. So it's sort of, one is the identity, if they would identify as being deaf as first, and they would put that first, or it's a child with deafness, diagnosed with deafness. So it becomes second. So it's sort of that idea of that identity first or that individual first. And like we said, this is all family choice. It's individuality as our kids get to be, have a say in that. They choose things, and which is where we want them to be and stuff like that. So why don't you guys talk a little bit about that, how that works in your family, how you navigate that, your thoughts.
Well,
Okay, go ahead, Sarita.
no, I was just gonna say, I think we acknowledge Elijah first. Like he is Elijah. That's who he is. We recognize that he has differences and disabilities, but he is Elijah. And so we acknowledge him first. And I think it's automatic for us, when we're talking about him to other people, that we do that, and they just kind of follow suit. I think, personally, I think if you're unsure, you should always acknowledge the person, because I think you're right, Molly. I think it's an individual preference type thing. You know, I think it's going to vary from person to person. But I think in terms of respect, I would automatically acknowledge the person first. Just I would, and it could be because this is our life, you know. I would always acknowledge the person first, and if they, of course, want something different, you know, I hope they would tell me or correct me, or it's something that I could pick up on just in our conversation. So, but out of respect, I would always acknowledge the person first, because that's what we choose to do for Elijah.
So my daughter is a person on the autism spectrum, and depending on who she's with and the circumstance that is surrounding her, she will identify as person first sometimes, because she also has a genetic condition. And so it just really depends, but she tends to be identity first, especially within the autism community. And that's one of our communities that we know more and more through the years that is identity first. So an autistic person. And she's very comfortable with saying that. And that is her choice, and it needs to be her choice. For our son, he goes with the flow. But I will say, we came to the perspective a long time ago, and this is a touchy subject, but I'm just going to throw it out there. He identifies as a person first with a disability, and he has no shame in that term of disability. It doesn't make him feel bad about who he is at all. It just so happens that he happens to have a disability. And we moved away from the term special needs long ago, because everybody has needs. I am not a special needs parent who needs to buy special needs toys for my special needs child. I am a parent who needs to help my children to reach their best potential possible and support them in those means. And they have human needs like everybody else. They have the human need to be included. They have the human need to have circles of friends, and they have the human need to get the best education possible and to go out and be employed in this month, this awareness month of awareness for disability employment. So that is, we go either way, depending on the kid in the moment. And bottom line is just ask the person. What is it how do they like to be referred to? And my daughter usually says, I'm Emily, just like we've got Elijah.
So, and kind of going on what you said, Linda, and the individuality of the family, and allowing the family to really choose the way they want to use language. I have two small children. I have a 9-year-old and a 5-year-old. My son, who's 9, is now just starting to understand his autism. And he does refer to himself as autistic at times, but I choose to use people first language. As he gets older, he can choose what he would like to use and what he wants me to use, and I will respect that. But with my daughter, I always use people first language. And the reason I do that is because I believe that their diagnosis, autism, Down syndrome, it is a part of who they are. It is definitely something that impacts their life every day, but it is not entirely who they are. And they are extremely unique individuals. Both of them are complete opposites, and they keep me very busy, going in totally different directions all the time. But I wouldn't want it any other way, because they're perfect for me and they're amazing. They've taught me so much about life. And then one thing I wanted to mention too, as far as giving parents the choice and using people first language, asking the family. I think using people first language, it's not a matter of political correctness. It is a matter of respect and manners and understanding the language yourself and what implications that may have on families, the way you use language, the way you refer to a child. So I've had people say to me, I've actually had this happen. Someone said regarding another family, they had a child on the downs. And that was shocking for me to hear as a parent of a child with Down syndrome on the downs. I don't even understand what that means. I still don't. And that was years ago. But that's sort of what I mean as far as being aware of the language that you use and how it impacts families and their perceptions, their understanding, especially in my line of work where I work with families who have young children who are newly diagnosed. They don't understand oftentimes that there's a medical model or a social model, or what is people first language, what is identity first language. So these are all ideas and concepts that they're just being introduced to. And as professionals, I believe that it is our duty to inform them accurately, honestly, with no bias. We have to leave that at the table, at the door, because when we're interacting with families, we don't know at what stage in their acceptance and understanding of this diagnosis. We don't know where they are, and we don't want to impact them negatively. We want to inform them honestly, accurately, and provide them with resources that are really going to inform and support them in whatever decision they make for surgeries, for whatever. And I believe that connecting them to families, to other families, whether it's online or national organizations or local organizations, families need other families. We need to know that what's going on with, in our group, not just with Down syndrome, but in disabilities in general. We need to understand the different changes in policy, the changes in services, the changes in different systems, and how to navigate that. And you learn that best from other families because they're the ones who are using them day in and day out. So that piece, I believe, is such an important part of the puzzle for families to really know what is best for their child and what to do for their family.
So I'm going to just chime in because I know that Molly was going to ask if we had any one last thing, and I'm looking at the clock. And so I'm going to go, Molly, to my one last thing, especially if you are on the provider side, or just, a friendship side, whatever. But this is what I would ask of those who are working within the systems of care, that you please ask. And then you truly listen and give time for those responses and for hearing the stories of that journey, because every family has a little bit different story to that journey, and they've been impacted so significantly in that journey. So listen, truly listen, and learn from those responses, learn from the resources that are going forward, and then apply it and become someone who emulates the best of practices when it comes to language and delivery of diagnoses, and then teach others around you and be our ally with us and supporting families from the day of diagnosis all the way through to where they are in their journey. And help them have quality of life in the most positive way. Quality of life has been looked at so differently in this pandemic, for people with disabilities especially so. And we need to make certain we're seeing quality of life in the most positive and joyous of ways.
So my final comment.
Just
if
a
you
sec.
want- okay.
Just a sec, Marisol, so what I'm going to do is I'm going to share my screen so that I have everybody's contact information up. And then while I do that, then Marisol, why don't you go? And then Sarita, you go with your last, because I want to make sure we get all that information. I know everybody wanted to make sure that was out there, and we've got a survey. And again, we can't appreciate it enough for you guys joining and sharing, but go ahead, Marisol, and I hope it's not too distracting. Thank you.
No, not at all. And mine is quick too. I just wrote down my last words were, words have power and they matter. And I just really want to leave that. I want to leave that message with you today.
And really quickly for me, just the last word, I would say, when it comes to communication, it's two sides of it. There's a person who's talking, there's a person who's listening. And I think if wherever you find yourself on that communication wheel, I think you need to acknowledge and appreciate the person on the other side of it. I think if you're the person talking, you need to be making sure what you're saying is being received and it's being understood. If you're the person who's listening, you need to be okay with saying, I don't understand. And so I think we really have to just push the importance of effective communication and being okay with letting folks know when we're being ineffective, regardless of where we are on that communication cycle.
Okay, 1 minute left. Again, I can't thank you guys enough for coming and sharing your stories and your journeys and your thoughts and all of your wisdom. It's such an important conversation. It's a conversation that we know will continue to go. Thank you everyone for joining us today. We will be sending out follow-up. We'll send up a follow-up email to everybody who's registered with some resources that we have that kind of inform some of our decisions and our thoughts as we work through some of this. And we hope that you can join us on further presentations from the Family Center in the future. So thank you.